So mood disorder is going to encompass our bipolar disorders, our depressive disorders, and along with that, suicidality. For our bipolar disorder, bi meaning two, we have two kind of opposite ends of the spectrum within this disorder. We have a manic phase and we have a depressive phase. So this is a nice visual of those, and we'll talk kind of about them as we flip through these. But this is just a really good visual aid for bipolar. So we have a couple types of bipolar disorder. We have hypomania. This is going to be a hyperinflated and or irritable mood that's going to happen for at least 4 days. This is less intense than mania, hence hypo meaning under. We're a little above baseline, but we're not quite at mania. Hypomania typically does not require hospitalization, whereas mania usually does incorporate hospitalization because we have an elevation of mood that includes grandiosity and irritability. And with this grandiosity and irritability, we also have poor impulse control, which can put us at danger to ourselves and others. Some terms that we're going to see. Hypersomnia. This is excessive sleeping. Insomnia. This is the inability to sleep. Pressured speech, which is where we talk loud and fast. And flight of ideas, where we do that topic jumping. Okay. So we have bipolar 1, which is episodes of major depression, and we have some manic or hypomanic episodes. Bipolar 2 is going to have depressive episodes with some hypomania, not mania. Cyclothymia is going to be hypomania with minor depression. So this one's a little harder to find and treat because the ends of their spectrum are not so extreme. And then bipolar unspecified, we have mania or hypomania, we have depression, but it doesn't fit into one of those 3 categories. I don't necessarily expect you to know these, just know that, there's different classifications between the depressive episodes and the types of mania that you have. So things that we're going to be assessing for bipolar, their mood. Mood is subjective. Mood is what they say it is. Affect is going to be objective, so that's what we're visualizing. So, and then there is incongruent. So this is when the objective affect is flat, but the client says they're happy. That's incongruent mood and affect. Some physical signs and symptoms that we may see is, and that we're going to want to assess. Sleep. Manic patients do not sleep. They can be up for days at a time. So our Maslow is not being taken care of here in this manic phase. Sometimes we're not eating, we're not sleeping, which exacerbates the problem even more. We have hypersomnia, which is where we fall asleep a lot, but we're waking up a whole bunch. So we're in the bed and kind of sleeping excessively. This comes during the depressive phase because hypersomnia also happens in depression. So this is part of our depressive phase of bipolar. So one of the medications that we use is lithium. Big thing to know is your lithium complications. So big things that we can have is GI upset. I mean, we're just going to take it with meals. That's not a big one. That fine hand tremor. The issue is when that tremor becomes coarse, because that's a sign of toxicity. Okay. Polyuria and thirst. Remember, we want to stay well hydrated because sodium impacts our lithium levels. So we want to make sure we have adequate sodium and adequate water intake. We can get weight gain. We can get renal toxicity, so we want to monitor that INO, BUN, and creatinine. And that is why our water intake and fluid intake is also very critical. It can cause goiter and hypothyroidism. So we're going to want to monitor for signs and symptoms of hypothyroidism and monitor those T3, T4, and TSH levels. And we already talked about the adequate sodium and potassium in fluid. Lithium toxicity, our safe range is 0.6 to 1.2. And as we increase in our levels, the worse it gets. So starting at about 1.5 to 2, we kind of have this confusion in uncoordination. Then we move on to advanced tinnitus, hypotension, and you could die. And then severe, where you're going to have oliguria, seizure, coma, death, and you have to have hemodialysis to get the lithium out of your body. So big kind of key points in here. Oops, here's this one. So big points: goiter and hypothyroidism, electrolyte imbalances, and that polyuria and thirst. I did include a drug information table on lithium and valproic acid. I don't have a sheet on valproic acid in here with fill in the blanks on it, but I do need you to know some of the things about valproic acid, like that it causes liver toxicity, it can cause thrombocytopenia, and is tetragenic. So you will need to know that, because valproic acid, while it's an anticonvulsant, it can be used as a mood stabilizer as well. Okay. So our expected outcomes: we want our patient to eat at least 1,500 calories in 24 hours. We want to make sure the patient refrains from hurting themselves or others, and we want to make sure that they sleep and rest for at least 6 hours. And we want to demonstrate decreased pressure of speech, flight of ideas before discharge. Priority: keep the patient safe, and we have to help them meet their Maslow's. So provide high calorie intakes that they can take on the go, because these people are pacing and moving and they can't sit still for very long. So we are going to provide those protein bars, protein shakes, sandwiches, anything that they can take on the go. If they start getting upset, we may take them to the gym to relieve some of that energy. But we don't want to make them do something that requires a whole bunch of concentration. We want to administer medications. We want to make sure we provide restful, peaceful sleep and use our therapeutic communication, but we want to set limits and be consistent but non-threatening during that time. All right. So then we have our bipolar nurse in the making. It kind of goes through the manic phase and depressive phase, and it's just a good little visual aid. And there is one on lithium. There's a drug information table on lithium, and then there is a drug information table on valproic acid. Oops. Okay. So now we're going to talk about our depression and our different types of depression. So this is just a really nice, I think, visual aid of our depressive disorders and our SIGI caps for our depression assessment. We're going to assess for sleep disturbances, decrease interest in or pleasure in activities, that anhedonia, guilty feeling, energy decreased, issues with concentrating, fluctuating appetite, decrease in psychomotor function, and suicidal ideations. Okay. I do have a nurse in the making that talks about the different types of depression, because I'm going to talk about a lot of major depression in this fill in the blank, but you need to know the difference between premenstrual, substance induced, and seasonal affective and postpartum. Okay, but that's a great little visual aid that sums up everything. Okay. So major depressive disorders. This is going to be an overwhelming feeling of sadness, an inability to feel pleasure, which remember anhedonia, weight gain or loss that isn't due to dieting, sleep disturbances, fatigue, energy loss, feelings of worthlessness, and suicidal thoughts, and that psychomotor retardation. So we get a diagnosis of major depressive when we have 5 of these symptoms for at least 2 weeks. There is some caveats to that that I know is in your book. Like if someone has a major loss, we'll go ahead and start treating to prevent. But typically this is our diagnosing criteria. Okay. So our major depressive treatment. It's thought to be caused by a serotonin deficit. So the medications that we use are medications that increase serotonin. Our MAOIs, our SSRIs, our SNRIs, our TCAs, and our atypical antidepressants, which I have more sheets on, like a pharmacology sheet. All of these things have the possibility to start or to cause serotonin syndrome. This is an overdose of serotonin in our body. It's life-threatening and can start within 30 minutes to 48 hours. Change in mental status, increased pulse, and up and down blood pressure. We're going to lose our muscular coordination. So we're going to spike a fever. So we're going to treat it by discontinuing the medications, giving IV fluids, and decreasing the temperature with antipyretics and cooling blankets. All right, so SSRIs, fluoxetine, citalopram, sertraline, all of these are SSRIs. They increase the serotonin, and we want to take them in the morning. Big thing to remember is it takes a few weeks to start working. You will not get immediate relief from depression symptoms. Our complications include weight gain, sexual dysfunction, and teeth grinding. Once again, serotonin syndrome. I know the times are different. They differ between sources. I just need you to know that it can happen within the start of it and a few days after. And again, confusion, disorientation, hallucinations, delirium, seizures, tachycardia, fever, apnea, death, fluctuating blood pressures. And when we start an antidepressant, we are at an increased risk for suicide because it takes 1 to 3 weeks to start working on the depression, but it helps our energy level almost immediately. So now they're still depressed because it hasn't started to work on their depression yet, but now they have energy, so they have the energy to complete a suicide attempt. And then I have a nice little drug table in there for you. And then we have venlafaxine and duloxetine, which is our SNRIs. So they increase serotonin and norepinephrine. Of course, we can get serotonin syndrome, sexual dysfunction, and hypertension. All that's pretty much the same, with the exception of the hypertension. And then we have our atypical antidepressants. Typically we're going to see trazodone used for insomnia because of the sleepiness that it brings, and we can't have grapefruit juice with that. And then we have our bupropion, which is our Wellbutrin. This is one we see a lot. This one's going to increase dopamine and norepinephrine. It does have the potential for anti-chlorogenic effects, so we treat those always the same. We have increased heart rate and blood pressure, restlessness, and seizures. So we need to be mindful of that. And then there is a little drug table in there on our SNRIs and our bupropion. Then we have our TCAs, our tricyclic antidepressants. We have amitriptyline and nortriptyline, going to increase serotonin and norepi. Takes about 2 weeks to see effect and 1 to 2 months to see full effect. Big things. Orthostatic hypotension, that's big. And y'all know your interventions for that. Get up slowly, drink lots of water, all of that. So they are a fall risk. Anti-chlorogenic effects, so we want to make sure that they're eating, peeing, pooping, drinking all adequately. Can cause some sedation. It can cause cardiac toxicity, so we're going to want to get a baseline EKG. And it does lower a seizure threshold, so this is not for somebody who has seizures. And you can become diaphoretic. I got a drug table in there. And we got our MAOIs. Phenlazine is our big one. Blocks the MAOI enzymes, increases norepi, dopamine, serotonin, and tyramine, and has an onset of 2 to 4 weeks. So big things that we can have. We can have CNS stimulation. We can have orthostatic hypotension and a rash. We can also have a hypertensive crisis when mixed with tyramines or certain drugs. So big things, SSRIs, SNRIs, TCAs, carbazepines, all are going to increase serotonin syndrome. Serotonin syndrome. Our cardiac disease, let me use a different color. Our cardiac disease, diabetes, and seizures, it can increase the risk of heart disease, diabetes, and seizures. So it's going to exacerbate that more. So we don't want to give this to these friends. And then things like ephedrine, amphetamines for like ADHD, pseudoephedrine for nasal decongestant, or diphenhydramine like Benadryl. And tyramines are going to cause that hypertensive crisis. Okay. So here's a nice list of our tyramine-rich food. Aged cheese, smoked meats such as pepperoni and salami, avocados, smoked fish, soup, soy sauce, beers, red wines, and bananas. A big thing to note that I see come in a lot on NCLEX and ATI is this aged cheese. Remember, cottage cheese is not aged cheese. You can have cottage cheese and crackers. All right. Then we have our non-medicinal treatment. So we have our ECT, electroconvulsive therapy. The goal of this therapy is to produce a seizure that lasts 30 to 90 seconds, and we're going to have about 8 to 12 treatments over a few weeks. It's going to be done outpatient in the morning, and the risks are going to be increased intracranial pressure, hypertension, and dysrhythmias, along with short-term memory loss. And we also need to follow our pre-op and post-op protocols. So NPO, pre-op, post-op, we want to maintain a patent airway. We need to do all of those things as a priority because we need to make sure that they're safely coming out of that anesthesia. Complementary and alternative therapies, we have our St. John's wort. Big things is we shouldn't take St. John's wort with any prescription antidepressants, especially SSRIs or MAOIs, because of the risk for serotonin syndrome. And then there are other types like music therapy, art therapy, expressive journaling, writing, those things. And back a couple pages ago is a couple of our drug sheets from Nurse in the Making that are really cute. And then last but not least, we need to make sure that we are responsible for identifying patients at risk for suicide. We want to assess for changes in ability to fulfill family, social, or occupational obligations. Note changes in weight, appetite, and patterns of eating, and inability to concentrate or make decisions. Other things we need to do. Remember, assess unless in distress. If we have a patient who has attempted to kill themselves, take a bunch of pills, and they call in, we need to go get the patient before we even ask any other questions, because we need to make sure that they're okay. So we need to assess the situation unless we're in distress. And distress would be we cannot actively lay eyes on the patient right now. Okay? And that's it.